one thing that I always do, and you alluded to gait training, but that's one of my favorite things to look at first is when walk, like just how somebody walks in the door. If you have acute plantar fasciitis, I'm probably going to know when you walk in the door because you're going to be real ginger and gentle in that foot that's bothering you, right?
Right.
So that's usually my first telltale sign. But a lot of times I'll watch people walk, and what I'm looking for again, how does your big toe move? How do your feet move? Do you collapse more on that side that's painful than you do on the other side, right? Um, how does your knee move? Does it move in and out? Am I seeing compensations up at the knee that tells me that your foot or your ankle is too tight or your calves are too tight, right? So I'm kind of looking at all of that. And then, once I get them on the table, again, I'm looking at that joint play. How is your midfoot moving? How is your big toe moving? How is motion in your ankle? I'm assessing, calf tightness, seeing like, are we tighter lower towards the Achilles and the soleus, or is it more tension up at the gastroc where we need to kind of work through that? So kind of just looking at that in general, looking at how they're standing, right? Even looking just with somebody, barefoot in front of me, I can see, are their arches even collapsing even to just support them when they're walking or when they're standing there, right? Does one collapse more than the other? We can look at that navicular, which is one of your bones on the inside of your foot.
Mm-hmm.
I usually just put my thumb on either side and then have people shift weight and watch to see if we get a drop. We call that that navicular drop.
Mm-hmm.
That can cause a lot of issues. If your navicular is dropping, that tells me that you have some weakness down here, and that's probably going to predispose you to something like this if you're not having that support in your shoes and in your routines the way that we want to. So that's kind of my take. I don't know if you have anything to add to that as well, but
Yeah. I mean, we look at a lot of that stuff as well too. I mean, always paying attention. I think every physical medicine practitioner is always looking at how their patients walk into the door, how their clients
absolutely.
walk into the door.
Mm-hmm.
And of course, maybe this goes without saying, but we might as well say it too. All of that you just did assessment wise, of course, is with shoe off, right?
Yes,
so
absolutely.
so
Good
yeah,
point.
anybody ever come in and they're saying like, hey, I want to like work and assess on feet. First of all, I think the amount of times that we get like people act surprised where I see it on like the chiropractic side. They're like, wait, you could do work with my feet? It's like, yeah, it's a joint, it's a muscle group, it's part of the
Absolutely, I can.
musculoskeletal system, like we can.
Mm-hmm.
So I think there's always just a little bit of that surprise from people because they're like, I thought you were just a back doctor. It's like we do so much more than that. Like if it's
Mm-hmm.
we're musculoskeletal experts, you are as well too with your massage and athletic training. Like that includes everything, right? So that little ramble aside, I think all of that stuff is great with gait assessment. Definitely fantastic. I definitely put a lot of credence and a lot of stock into functional muscle testing.
Mm-hmm.
And I also really like active and passive range of motion, right?
Mm-hmm.
So I'll first have the patient when they're on the table. The nice thing too is if we do have like a unilateral plantar fasciitis, in theory, your other side is normal. So it does give us like a test control back to the other side to say like, okay, how are you moving on that side? We go to test something like dorsiflexion and then you come all the way up to here on this side, but you only come to there on that side. Aha, we think we're on to something, right?
Right.
But a lot of range of motion. Usually I'll have the patient try to contract it first and then I'll add over pressure so that we can test active versus passive. And then it's really valuable to then do like functional muscle testing. There's actually really nice ways that you could set up these muscle tests on the table to more specifically target individual muscle groups that cross that ankle
Mm-hmm.
complex. So definitely testing like the calf and the soleus separately, like tibialis anterior, tibialis posterior. Always gonna do a little bit of like that big toe strength test, and if they have the big toe up and I can melt it down like butter, and that's probably a problem, and that's probably
Mm-hmm.
part of the reason why the plantar fascia is going to be a problem. And then a lot of it is the how we fix it, but I always start with jumping right into the McKenzie exercises and seeing if we get those changes immediately back and all those functional gains that we had. And then, of course, paying attention to how the patient leaves at the end of that appointment too, how they're walking.